Bismillahirrahmanirrahim. So this is the third MCQ test of our MCQ series. First of all, I want to tell you people that you must remember, you must be focused now, because CPSP is going to conduct the exam in time, and the theory exam is most likely going to happen in time. So just forget any kind of ambiguity that the written exam is going to be postponed or late, because there are almost 90% chances that CPSP will conduct the exam. So let's start the third MCQ test, and after this third test, we Alhamdulillah would have completed our pediatric section for the our attempt. So pediatric section will have almost been covered in all these three tests. So even if anybody wants to have a quick review of pediatric section, there are only 20 minutes of each uh, test, and you can see the video. So let's start the first question. That was a 10-year-old boy, he presents with a click in his knee. So this question has been repeatedly tested, because there is always a confusion in candidate between two things. The correct answer was 5, popliteal and Baker cyst. Both are the name of a same thing. So the most important thing which in this question I feel was the location. If the question has mentioned the location, because the popliteal Baker cyst or popliteal cyst, it is mostly between the medial head of the gastrocnemius and the semimembranosus tendon. So always remember the location of this popliteal cyst or Baker cyst. It is very important, and if the location has been mentioned, then go for this question. In 2019, the question was tested. It was very confusing. Only clue was about the location. And what else CPSP test? They test presentation, location, and treatment of the cyst. And other than that, they discoid meniscus. They confuse you with the discoid meniscus as well. Now the next question was, a 10-year-old boy presents with unusual gait pattern. So as you know, I have mentioned in this question neck shaft angle, HE angle. This is a question is basically is of as you all know, Coxa vara. So the correct answer was 55. So this is the correct. What is the treatment? When the surgical treatment of this Coxa vara we go in the indication if the HE angle is more than 60 degree, and if HE angle is 45 to 60, and if symptomatic, then the progression of virus is very high, and the patient is most likely to require surgery in future. Sometimes they do not test you with HE angle, they test you with neck shaft angle. So remember, what are the indications of surgery? At what angle, at what point you have to go for the surgery, and after case hip spica abduction pillow 4 to 6 weeks. So Coxa vara treatment, surgical treatment, what are the indications? These are important to remember. And what CPSP they test the treatment based on neck shaft and HE angle. And what is Fairbank triangle? Fairbank triangle is seen at the inferior portion in Coxa vara. So remember this thing. Next question was, in metatarsus adductus, what is the possibility? So the possibility, the correct answer is 3. Metatarsus adductus, there is a difference between metatarsus adductus and skew foot. The option 4 is basically for a skew foot. So hind foot is normal in metatarsus adductus. Remember this thing. So I have also told in the explanation that adduction of forefoot with normal hind foot, basically normal hind foot and adduction of the forefoot, this is what we call metatarsus adductus. And what CPSP has tested, often the rotational profile disorders have been tested. So you must have a good grip on Stahelli rotational profile. It is also mentioned in my book of clinical exam, so you must have a good grip on this. Then the next question was, neuropathy in dorsal root ganglion accompanied by the loss of peripheral sensory nerve fibers and the degeneration of posterior column of spinal cord is the hallmark of, and the correct answer of 1, the option was Friedreich ataxia. So those who are only watching the video, they must know that I share the questions a day before in the group, so the answers are then discussed in this video. So answer was 1. Now CPSP tests you in different ways. They like to test these disorder. If you see what is the problem in spinal muscular atrophy, SMA, what is the problem is Friedreich ataxia. Loss of alpha motor neurons is in spinal muscular atrophy, and in Friedreich ataxia, it is autosomal recessive condition characterized by spinocerebellar degeneration. And CPSP often test the genetics, and then they like to test the progression. Also remember this clinical triad of Friedreich ataxia. Then there was a question. This question is basically, if you if you want to know, first of all, diagnose the treatment. First of all, go for the diagnosis. The diagnosis of this question is, this is congenital knee dislocation. And what was the answer is surgery. The clue to this question was, after 3 months, she presents to you with the ability of 20 degree of flexion of the involved knee. And if you see, what are the indications of operative treatment? The operative treatment is failure to gain 30 degree of flexion after 3 months of casting. And as in the question, it was mentioned that the casting has been done. There is a classification for congenital knee dislocation, and this is Tarek classification. He classified in G1, 2, 3. And the goal of surgery is to obtain 90 degree of flexion. Post-operatively, the cast is applied 45 to 60 degree of flexion for 3 to 4 weeks. And second decade of life. I think this is nothing to do with this. So the options, operative treatment indications are these main 3 indications. So our question was related to the first one. CPSP has tested congenital knee dislocation and the treatment as well. What is policization? So the correct answer was reconstruction of the thumb. So this is the picture of policization. And now what associated other questions can be tested? Radial club hand, types of radial club hand, classification name of radial club hand, and associations in which type thumb is present, in which type thumb is absent, and treatment with respect to age. At 6 months, what you are going to do, and at 9 to 12 months, what you are going to do. Then the last deformity to be corrected. Now they in exams they like to test in Ponseti method. What is last to correct? What is first to correct? And you all know the famous cave formula, and the correct answer was equinus. Clubfoot presents as what deformity? And the correct answer was equinocabovarus. Overcorrection of CTV, this is also a simple question, and the answer was rocker bottom foot. And what is the best management of CTV in newborn? So this is a bit tricky question. So if you will say manipulation alone, no, manipulation alone and corrective splint as well. So there was a question, what is the ideal age for the patient of CTV to apply cast? The options were first week, second week, third week, fourth week. Even if it is written first day, go for that option as early as possible. Cause of secondary clubfoot at birth are all except. So the correct answer is poliomyelitis, because as we all know that poliomyelitis develops after birth. So the answer is 3, poliomyelitis. Then this is a spot diagnosis. It will also help you in your talks. So as you all can see that the examiner is asking 16-year-old female. She has underwent a corrective foot procedure when she was a young child, and now she presents with a deformity. So there was some procedure, and the correct answer was talibase equino. Whereas first of all, you have to diagnose what is this. This is dorsal bunion. Dorsal bunion. Why it develops? There is imbalance between forces. And what is the imbalance? I have mentioned here in the explanation that this is the imbalance that causes the dorsal bunion, and most likely it develops after talipes equinocabovarus CTV. Although in our population I have only seen one case developing dorsal bunion. Mostly we have patients with deformity of they develop the swing phase deformity of supination. But this specific dorsal bunion is less seen in our population, but you have to remember what are the different balances: primary imbalance and secondary imbalance. Then comes the all of the following are the key components, concepts of the treatment of CTV deformity with manipulation and serial costing, except, and the answer was this. Basically, we apply, our aim is in 70 degree of abduction, not 30. All the other four options, they correlate with the treatment of CTV, but the question was except. So, except and beside these, and all these are also given in exams. Do not jump right away after reading the first option that it can be the answer. No, do look at the statement of the question. Then, so we basically achieve 70 degree of abduction. Sometimes there is a question about the Dennis Brown shoes, DB shoes. So I have told you that this orthosis consists of a bar with a shoe that has 70 degree of abduction and affected side on the affected side and 40 degree on the normal side. This was also a question in the exam. If patient has CTV on one side, how will you apply DB shoes? So 70 degree on the affected side and 40 degree on the normal side. In the exam, the correct option included 30 degree on the normal side. So then comes the TA transfer. TA transfer is appropriate option for which of the following patients? So the correct answer was 3 year. So when he dorsiflexes, this answer option can be more easy if the examiner would have mentioned when he has swing phase of his gait, but he preferred to deviate you somehow by mentioning dorsiflex instead of saying swing phase. So transferring of the tibialis anterior, this complication is often tested in exam. So this swing phase supination after CTV, you have to remember which tendon is transferred, tibialis anterior, where it is transferred, cuneiform. You must remember and you must go through this topic. Now, but CPSP has tested through CTV. It is very important topic. Many things have been tested, and there are few topics on which your grip must be very strong. CTV, DDH, Perthes disease, KFI, and these topics are very important. Then which of the following finding is most prognostic for the ability of a young child with cerebral palsy to weak? This was a question I remember once Tehseen Cheema Sahab, the great Tehseen Cheema Sahab, he asked in a conference. So this is very good question, and the answer to this question is ability to sit independently by the age of 2 years. The people who have solved the question that I sent must be knowing that I couldn't mention the correct options. So the answer is 1, ability to sit independently by age 2 years. This is very important question, and it is not only by the exam point of view, but also for your practice. When you will be practicing the CP patients, their parents are very much worried and they ask you whether our child will be able to walk or no. So remember, the child who is able to sit independently by the age of 10 years, he has high chances of walking by in the next future. So this is the explanation. You can read it later on. And a 6-year-old male child, CPA, he has limited ambulatory function. So this is a tricky question, but this tricky question includes some clues. First clue was that on physical examination, lower extremities are mildly involved, more involvement than the upper extremity. Sorry, the lower extremity, with the lower extremity there must be more involvement than the upper, and IQ level is normal. This is another clue. The answer was diaplegia, and we classify CP in different ways: physiology and by anatomy. Physiology, this athetosis, this line was also in a recent attempt of the exam. A scenario was mentioned, and in the end they said the patient is CP, he has constant slow breathing involuntary motions. Which type is this? So the answer was athetosis. So people were confused between athetosis and ataxia. So you have to memorize the classifications with one sentence description. So diaplegia affecting right and left side equally, Minimal spasticity may be present in upper limb, but lower limb spasticity predominates. IQ level may be near normal. So this was the question that I have tested, and this was the answer: diaplegia. How to differentiate diaplegia from paraplegia? They in paraplegia both legs are affected, but the arms are spared. But in diaplegia, arms are involved but less involved. And in quadriplegia, low IQ level and high mortality. So how to differentiate these three types? You must know. Which of the following is true regarding scoliosis in patient with DMD? So the answer was 3. In DMD, basically, scoliosis progression is much more than other diseases. So in DMD, we approach the patient and we offer surgical treatment at angle 20 to 30 degree. So how the other answers are wrong, I have also mentioned here. Most commonly inherited X-linked disorders. This is Duchenne muscular dystrophy. In exam, they like to test autosomal recessive, X-linked recessive, the genetics and the involved famous genes. They like to test it. So how the other answers are incorrect? CMT is most commonly inherited as autosomal dominant. Marfan syndrome, autosomal dominant. Larson syndrome, autosomal dominant or autosomal recessive as well. And Turner's 45X0. So mostly you will see DMD is as you have seen that DMD is X-linked recessive. So X-linked recessive are rare disorders, and DMD is one of these. So remember this thing. And this Gower sign is also seen in DMD. Overuse injury of calcaneal apophysis. These osteochondritis and these specific diseases, they have been tested in exam. So the answer was 3. Freiberg osteochondritis is second metatarsal. Sometimes they give a scenario and they said that the pain is in the second intermetatarsal space. So they tested different ways. You must be remembering. 7-year-old young boy had fracture of lateral condyle. He developed malunion as the fracture was not reduced. Anatomically malunion, what will it produce? So the answer was Geno Welcome. See, the lateral condyle is not going to produce any growth, and medial condyle will produce the growth, and as a result, the tibia will go outward. Geno Welcome will be produced. 14-year-old boy sustained significant distal femoral physeal fracture, assuming that he has complete growth rest. What is the predicted leg length discrepancy? That is 2 centimeter, because you must be knowing what different contribution of growth plates do in the lower limb and in the upper limb. Upper limb distal femur, we are talking about, it contributes almost 0.9 centimeter per year. And you also must know that in boys 16 year is the growth limit, and in girls 14 years is the growth limit. So this is a beautiful summary. Proximal femur 4 mm per year, distal femur 10 mm per year or 9 mm per year, proximal tibia 6 mm and distal tibia. So some questions can be tested this way. Which of the following is considered the best method to measure LLD in a patient with a knee contracture? So this is also an interesting question. You have to choose between these two, standard scanogram or lateral CT scanogram. When there is deformity in the lateral plane or when there is flexion contracture, then you have to go for the lateral CT scanogram. Lateral CT scanogram. And then this is the explanation. You can read it. And so these were all the questions that were included in the last pediatric session of the test. So I hope that I have tried to cover pediatric section in detail, and I hope that you will be having enough knowledge about the pediatric section. Now if